pleased to introduce Dr. Apostolopoulou, who's going to speak to us about critical pulmonary stenosis in the context of the small right ventricle. We don't use the term, I think, of the borderline right ventricle, but there's no question that it exists and can represent quite a challenge. So, Dr. Apostolopoulou.
Good morning from me. Thank you very much for the invitation. We're going to say a few things about critical pulmonary stenosis, which is actually defined as the RVOT obstruction, which is usually valvar. Sometimes it has an infundibular component as well. Most of the time, it's simple, pure, isolated PS in 70% of the patients. And obviously, it obstructs the RV emptying and the pulmonary blood flow, so it creates RVH and cyanosis. There's usually an ASD, obviously. And critical PS we actually define as the form that's in neonates and they need a PDA. It's a PDA-dependent lesion for pulmonary blood flow. You can see here, actually, it's not 1913, but you can see here the evolvement during time of how people have tried to address it, reaching what is actually the standard of care now, the valvuloplasty, as you heard from Dr. Anderson before. Now, if we say a few things about morphology, the pulmonary valve is usually dysplastic with uniform fibrous cone. Sometimes in 50% there are hypoplastic pulmonary arteries, and rarely there's post-stenotic dilatation, especially in dysplastic valves. And the right ventricle, let me get rid of something here that I can't see my slides. There you go. The right ventricle can have mild to moderate hypoplasia, rarely severely reduced. It's hypertrophy and has diffuse fibrosis. And the tricuspid valve can be normal in dimension in 50%. A lot of times in between, there's moderate hypoplasia and severe hypoplasia in 10%. RV coronary fistula is usually an issue with pulmonary atresia intact septum, but they can exist in critical PS as well. The right atrium is usually large and not usually has a PFO, obviously. And uncommonly, there's an Epstein anomaly of the tricuspid valve. So in terms of natural history, obviously presentation is nearly always within the first 2 weeks of life. They're very hypoxic and they die without treatment. Sometimes they live for a few months. Clinical presentation, they're obviously critically ill, irritable, tachypnic, and hypoxic. They're tachycardic, they have heart failure. Chest X-ray and EKG we always do. They're less informative, and obviously precise information is given by echo, cath if you need it, usually for the intervention, obviously, and cineangiography. The tricuspid valve is has significant incompetence in 90% and is competent in 10% in the initial presentation. Now, obviously, the cornerstone of our diagnosis is echocardiography. And what do we check in echocardiography? The pulmonary valve itself, its diameter and morphology, whether there's PI. And we measure systolic Doppler RV to PA gradient. We have to bear in mind that it may be underestimated, both in the presence of pulmonary hypertension, which is usually there because of the open duct, or with decreased antegrade flow if it's a very severely stenotic valve. We don't just check the pulmonary valve, obviously. We have to check the PAs, their diameter, and whether there's post-stenotic dilatation to check if there's supravalvular or peripheral pulmonary stenosis. Very, very important, the tricuspid valve, both its diameter and measuring with Doppler, estimate the RV pressure with due to the tricuspid regurgitation. Again, very important, the right ventricle, its size and its morphology. It's a bi or tripartite. Its function, is there RV obstruction, and whether it's a true RV obstruction or whether it's reactive. And obviously the atrial septum, is there an ASD, the shunt volume, the direction, is it left to right to left? And obviously check for AV malformations or whatever. This is a pulmonary valve obviously here, and this is how we would check and measure the systolic and mean gradient across the pulmonary valve. Now, medical therapy is essentially the use of prostaglandin, as Dr. Anderson said before. So we could keep the duct open, we can stabilize the patient until the planned intervention. Significant congestive heart failure could be treated appropriately with inotropes or diuresis for the right ventricle. That does not mean we delay the pulmonary valve intervention, the balloon usually, which is the definitive approach. And we have to bear in mind, we'll come to this several times, due to restrictive RV physiology, even after a successful pulmonary valve intervention, usually balloon, 20% of patients will need an alternative source of pulmonary blood supply for an X amount of time. This could be a prostaglandin infusion, ductal stenting, or aortopulmonary shunt. Now, I have to get rid of this somewhere. There you go. So if there's infundibular obstruction, the pressure gradient, we're talking about catheter therapy, which is the cornerstone of therapy in critical PS in the neonate, which means a balloon. We start with hemodynamics. If there's infundibular obstruction, as it is here, this is a very stenotic pulmonary valve, this is a dilated PA. The pressure gradient should be measured with an end-hole catheter across the RVOT, so we can hopefully discern how much of the stenosis is due to the pulmonary valve itself, how much is subpulmonary. It doesn't really change that we have to do a balloon, but it's helpful information. Obviously, RVDP and RA pressure are elevated in severe obstruction when the RV is failing. Angiocardiography obviously shows the location, anatomy, and severity of the stenosis as here. Usually it's done in anteroposterior and lateral views. This is a straight lateral view, for instance, here. Post-stenotic dilatation results from the jet effect and is not proportional to the severity of the obstruction. Sometimes we have much more dilated PAs with less stenotic valves. This is just to show you here the high RV pressure. This is a pullback, this is the PA pressure, this is the RV pressure. Catheter therapy, which is the balloon valvuloplasty. It's obviously the method of choice for pulmonary PS. It works worse in dysplastic valves, but really it's the method of choice for all neonates in this, with this lesion. The chosen balloon diameter is 100 to 120% of the valve annulus. And as I said, dysplastic valves usually respond less or not at all, but still that's the method of choice. Now, independent predictors of suboptimal outcome. I'm trying to get rid of this silly thing here, but anyway, I don't think I can get rid of it. Give me a second. There you go. I think that's better. No, give me 1 second and I'll try and fix this because I can't, it's in the middle of my screen and I can't see my slides, but anyway. Okay, then I'll get it down here. Thank you very much. Okay, where were we? Independent predictors of suboptimal outcome with balloon valvuloplasty, small annular size if the valve is, the baby's valve is very small, the achievement of increased immediate residual gradient right after the valvuloplasty, and a smaller balloon to annulus ratio if we use smaller balloon than we should have. There are several complications, as you see here, things that are true for any neonate having a significant intervention. And we have to keep in mind that we could have abrupt duct closure required urgent aortic to PA shunt, especially for through the duct, which is something that the wire a lot of times goes through the duct It's more stable if it goes through the duct, but we have to keep in mind this complication here. Now, pulmonary insufficiency. Risk factors for pulmonary insufficiency is smaller babies, larger balloons, larger gradients. And we have to keep in mind that pulmonary insufficiency progresses with time. So it's something that will come back to us and to the patients when they're in puberty or early adolescence. Now, catheter therapy. Are we doing it and everything's fine? No. Sometimes we cannot do it. We don't have to go through the numbers here, but you can see here that in some patients it's effective, some patients it's not effective. Even in the effective patients, sometimes we need a shunt. This is an older publication here. And even on our successes, which is the 68 patients from this slide, some of them are ultimate successes with further interventions or not, and some of our ultimate failures with a lot of things that may need to be done in the future. So it's not most of the time a curative intervention. So surgical therapy is obviously indicated if the catheter interventions fail or as a primary treatment sometimes in this dysplastic valve. Its aim is elimination of stenosis, and if we actually, as we heard in the aortic stenosis before, is trying to keep valvular competence, which is, as we said, important for long-term follow-up. There are several techniques. We don't have to go into that. And again, as we said, interventional therapy is not, it's successful. It's the cornerstone of therapy in these patients, but it's associated with further interventions as time goes by and further surgical intervention as time goes by for some of these patients. Still, it's the method of choice for critical PS in neonates. Now, follow-up, this is where things get a little more complicated. The decision towards a biventricular repair or 1.5 ventricular repair or univentricular palliation is based on the RV function and growth. Biventricular repair is when the patient is able to sustain its forward flow and that no extra pulmonary flow is needed, which means that we have a normal aortic saturation without right to left atrial shunt, not at the neonatal period, as the baby grows. Now, 1.5 ventricle repair, which is pictured here, is actually doing a bidirectional glen and using the antegrade flow of the IVC return to go through the tricuspid valve, the smaller RV, and the pulmonary valve, and the glen here. And in patients that cannot even sustain this type of physiology, we have to do a univentricular repair, which is usually total caveopulmonary anastomosis and Fontan. SVC, IVC, both in the pulmonary arteries. Now, fistula, as I said, it's more of a problem in pulmonary atresia intact septum, but sometimes in very, very small critical PSs, we can have them. What are sinusoids? They're primitive embryological remnants that initially supply the cardiac muscles. So they have connections to both cardiac veins and arteries before they involute. They are less than pulmonary artery intact septum in patients with PS. And myocardial perfusion can be either normal from the aorta or dual with competitive flow from the coronary arteries and the RV. And dependent on the RV, which we call RV-dependent coronary circulation, which is usually associated with stenosis in the true coronary arteries. Now, fistula can be considered a contraindication to RV decompression, but if we don't decompress the RV, the myocardial oxygen delivery depends on the RV perfusion and the oxygen saturation of the RV. The right to left shunt will keep oxygen saturation low, and high pressure in the right ventricle will lead to chronic subendocardial ischemia and RV failure. And essentially, if we don't decompress the RV, we essentially leading the patient towards univentricular physiology. And a lot of patients, even in pulmonary atresia and intact septum, can achieve biventricular physiology if we can decompress the RV. So early RV decompression, even in the presence of fistulae, of course, if there's no RV-dependent coronary circulation, is something we need to consider. Now, conditions that we can achieve biventricular repair is, of course, if there's no RV-dependent coronary circulation, a larger tricuspid valve annulus, a larger ratio of tricuspid to mitral valve diameter, significant baseline TR, and larger baseline RV area. And another issue, after decompression, significant PI that actually makes the RV grow as much as it can. This is a very busy slide, but just to show you that the baseline RV area is important, and in identifying patients who achieve biventricular circulation, patients with RV area more than 8 always in this publication achieve biventricular circulation. And again, what's important, TR severity, RV function and size, velocity through the pulmonary valve, and PR severity. All these are post-decompression, obviously. Initially, everybody has a very bad RV and a very stenotic valve. What we can achieve after decompression are the factors that can show you whether we can go to biventricular circulation or not. Now, I'll show you very briefly some of our patients, which is 3 different patients with this, of the same spectrum. This is a baby we just did like a couple of weeks ago. And you can see it's a very stenotic valve with a very small, like 1 millimeter opening here. We measured not the opening, but the annulus at 4. And we did 2 balloons. Well, this is a, what is it? 5 millimeter balloon, and this is a 6 millimeter balloon. The pressure was 103 before in the right ventricle. We ended up with 68 and same pulmonary artery. And as you can see here, there is a PI, which is at least 2nd degree, significant PI. And as you can see here, the right ventricle feels a lot better. There's still significant TR, and there's significant RVOT, not obstruction, but an overreactive RVOT, let's say. Now, this is a patient that actually needed prostaglandin for 8 days. We never stopped prostaglandin right away, but we tried it in a couple of days, and then a couple of days, and then a couple of days. At 8 days, she got off prostaglandin. This is the echo from 10 days of age. And as you can see, there's a lot less TR with a gradient of about 50 or whatever it says here, 58, I think. Okay, you see there's still some right to left shunting here through the PFO. And the gradient is actually at a max of 36. So she's actually at home and doing pretty well, and we'll have to see what she will be like going on in her life. Now, this is a critical PS that actually had a valvotomy because we couldn't get through the valve like a year and a half ago or something. This is
sorry,
yes.
Remind you of the time, please.
Yes, she's 10 months. Let's go further then. And now we have her at 2 years. She's cyanotic with crying. You can see here that there's right to left bowing here and a lot of TR, okay? She doesn't have a significant stenosis. And you can see here in several views, there's still right to left through the ASD. And this is an RV that's tripartite, but maybe not as big as you would expect it. We're waiting to cath her, but I have this feeling that she may be one of these patients that need 1.5 ventricle repair. Trying to go to the next slide. There you go. This is actually a patient that's 22 years old now. He's a university student, CPET 31. 25 days, he had a neonatal valvotomy at Hagia Sophia. 25 days he needed prostaglandins. He actually did not have a BT shunt because he had an infection. See how good he looks at 22. This doesn't play, but hopefully it will. Of course, the RV is big. The pulmonary valve is not stenotic. He may need something in the pulmonary valve, but he's 22 and nobody expected it. Factors of ultimate success, the RV compliance, which is partly but not solely determined by the RV size. The poor compliance can result from myocardial ischemia and fibroelastosis. It leads to poor ventricular filling and right to left atrial shunting and cyanosis. There's no medical improvement, medical treatment for the RV compliance per se, so we wait on prostaglandins for as long as 3 weeks, and often, sometimes even at 3 weeks, we can discontinue it. Otherwise, we have to do a shunt. And the shunt itself, if the RV compliance improves, it can clog or be removed. Long-term follow-up, we keep a close eye on them with all these modalities, as all long-term survivors of critical congenital heart disease. We have to keep an eye on the PI and see how bad it gets and if they need an intervention for the pulmonary valve. In conclusion, critical PS is a ductal-dependent lesion that has various degrees of hypoplasia and dysplasia of the tricuspid valve, RV, RVOT, pulmonary valve. Obviously, balloon valvuloplasty is the initial procedure. Otherwise, we have to go to surgical valvotomy with or without RVOT surgery. The main factor guiding the patient's course is RV compliance, and additional pulmonary blood flow, either with a PDA or a shunt, may be needed until the RV compliance improves. Baseline RV and tricuspid valve, tricuspid regurgitation, and post-compression PI are important prognostic factors. So the RV can improve in size and compliance and regulate the amount of blood flow through that the RV is able to manage, and therefore guide the patient to biventricular, 1.5 ventricular, or single ventricular physiology and determine his long-term course. Thank you.
Thank you. Very comprehensive review of pulmonary stenosis.